Good afternoon and welcome to another MediMobile webinar. For today's webinar, we're doing your billing questions answered. To do this, we polled about 5,000 doctors, admins, and billers, and we got a whole bunch of questions. We want to thank you for taking the time to ask those. And of all those questions, they came into these three categories that we're going to go over today. The first will be correct evaluation and management coding based on place of service. Then we'll get into billing multiple CPTs on the same data service and wrap this up with some procedure-specific inquiries. I would like to make a note at the bottom of the page. You can see that all macro questions we will handle in another webinar. We continually learn more and more about that as time goes on, and we will present you with the most up-to-date information at another date. For today's questions, we do have a guest expert for you. Her name is Morgan Kroll. As you can see, she's been doing medical billing and management for over 20 years, and we're very fortunate to have her here at MediMobile. She owned a multi-specialty medical billing company for a number of years, and we're very fortunate to have acquired that a couple years ago, and she's been doing consulting for a greater portion of a decade. We're going to get it kicked off with correct evaluation and management, and Morgan will take it from here.
The first thing I wanted to talk about is one of the biggest denials we see are the proper documentation of a patient being in observation versus being in an inpatient setting. So when a patient is in observation, typically utilization management requirements are different. So they don't typically require authorizations. So when you bill an observation stay in inpatient, you will get a denial for no authorization. So a provider will really need to be aware and try to track when a patient is observation versus when they get placed into an inpatient setting, largely due to the managed care criteria and requirements regarding authorizations and care. So I think that kind of covers the number one reason we see. The number two issue we see a lot of that I think is fundamental and comes and goes is the fact that we see a lot of denials, not just for necessarily place of care or place of service. We see them because consultation codes are being billed for managed Medicare plans. And so it's very important that your staff or the hospital make clear that a patient is managed Medicare if you're doing a consultative service. Managed Medicare plans follow Medicare. So if you're billing a 99251 through 255 and the patient's a managed Medicare, you will receive a denial. It will delay your revenue. I think that is kind of all we kind of talked about with place of service at this point. Feel free to ask any additional questions. We were asked basically to talk about the things we see that most delay inpatient or hospital-based revenue, and those are the two items we see the most of. So to go to the next one, the specific question that someone asked, they ask if the first visit at the office after a hospital discharge, what would be the appropriate code that they use, a new patient or a follow-up visit? Correct coding as far as both the CPT coding and Medicare consider that a patient is a new patient if they have not received any professional services from a provider. And when I say provider, that would be anyone billing under the same tax ID and same NPI. That is considered a provider within the past 3 years. So if you've seen a patient in the facility, you would bill it as an established patient. So let's say the patient came in, depending on the acuity level of the patient, you would want to bill anywhere from a 99211 through a 99215. So that is the answer to that. And then Medicare basically considers a single provider, anyone seeing that patient who bills under the same tax ID and the same NPI. Medicare does require a face-to-face visit. Okay. We had another great question regarding network, and it was regarding, can an insurance company deny payment for inpatient services? And it says critical care medicine with subsequent visit code 99233 if the provider is not in network with that particular company. They can deny. Inpatient care should be covered at all times, especially in an acute setting. We do see a lot of denials for critical care in conjunction with an E&M on the same date. A lot of times that is the only caveat to where you can bill a critical care encounter with an inpatient visit on the same date, you would append a modifier 25 to the non-critical care, and then you would most likely need to send records. But beyond that, we'll talk about the out-of-network. So inpatient care will be covered. There is a propensity for out-of-network providers, even at the acute level, to receive denials for no out-of-network. However, a billing agent can appeal that, because if the facility is in network and they have an authorization on file, your claim is eligible for payment and reconsideration. I would say the vast majority of our hospital-based providers are out of network, and we see about 10% of our claims denied for that reason. So it's not a huge number of denials, but we do see them and we appeal them appropriately and they get paid. If a patient is an HMO and is admitted inpatient, the authorization will cover both the referral and the stay. If a patient is observation, the group who's out of network may see a denial for no PCP referral on file. A lot of people are not aware, or a lot of groups are not aware, that only the attending physician is required to have the referral on file. So all consulting providers, as long as the attending has the referral on file, the consulting providers should be eligible for reimbursement. That's in network or out of network. And then if the patient went through the ER, the referral requirement on an HMO is actually no longer applicable. It'll be covered under the fact that the patient went through an emergency room situation. So that out of network you may have to appeal, but as long as the facility has an authorization and as long as there's a referral on an HMO-based plan and observation stays, not inpatient but observation, your claim should be eligible for reimbursement by the regulatory oversight both by your state and CMS. So, and then what brought another question up with that is, why would people want to be out of network if there is a chance that their claims would be denied for no out of network status? A lot of facility-based providers would consider staying out of network because the fee schedule methodology by which the plan creates the allowables or the usual and customary payments is very different, and it definitely elevates the allowables and the reimbursement for the provider group. So if you guys have any questions about that, we can go into more detail. There is a methodology that they use to determine what a fee schedule for out-of-network versus in-network is. It's fairly complex, but I would be happy to answer it if you are interested. So what you'll find is some provider groups who are not tied by hospital contracts can be out of network, choose to be because of reimbursement. Larger groups tend to have to be in network because of their hospital contracts. So billing, we're going to the next question, which is billing multiple CPTs on the same date of service. CMS and the regulatory and all the private plans and regulatory oversight do not allow for multiple CPTs on the same day by the same doctor, with the caveat of two different. You can bill extended care codes in addition to the base code. So if you bill like a 99232, you would bill a 99356, that is accepted, or you can bill critical care in conjunction with an E&M code. But other than that, you cannot bill more than 2 E&M codes on one day. So the question specific was, how do you handle it when a patient is billed for an admit by the night doctor, then billed as seen same day by the day doctor? So that would be ultimately the responsibility of the group. If the patient came in and was seen and discharged on the same date, it's really up to the group on who they assign the CPT code for. First of all, the code would not be observation, which we see a lot of. It would be transitioned to the same day admit discharge code. And then the group would have to decide who they wanted to give credit for. So some groups struggle with this because they pay their providers on a basis of collections. And that's where it becomes a little more stickier to decide who gets that. So typically, a lot of our groups that I've worked with and consulted with, they give a nocturnist a stipend. So in that situation where it's the same day admit and discharge, they decide to give the other provider the actual visit, and they change it to the same day admit discharge code. Now, the caveat to that is if the nocturnist is a physician and the day provider is an extender, you would want to give it to most likely the nocturnist, because extenders, meaning nurse practitioners and PAs, only make 85% of what a physician does. So you want to optimize the group's revenue. You don't necessarily want to give that to an extender who is automatically generating a 15% loss. Okay, critical care codes, as I mentioned again, and extended care codes are excluded from the multiple billing rule, so you can bill with them, but you must document must validate the necessity, and with extended care, the time frame, as well as if you're going to bill extended critical care codes, the time frame as well. So, okay, so we're moving on to the procedure-specific inquiries. We had one procedure-specific regarding removal of benign lesions. When seeing a patient as an outpatient consult and billing with CPT codes 99243 through 99245, if the patient has been billed for ICD-10 and encounter for another, oh, I'm sorry, I actually went to the wrong question. This is actually if you can bill multiple times for a pre-procedural exam within the 30 days. You actually can, but it's all going to rely in your documentation. So when you're billing, you're originally seeing the patient, and it's a non-Medicare, non-managed Medicare patient. Let's say you bill a 99243. They get their blood work done. They get an EKG. There's something abnormal that delays the surgery, or there's some other issue. You can bring the patient back in. To ensure reimbursement, you want to include the surgical diagnoses first, the reason, the Z code for the preoperative clearance, and then reasons, all associated comorbidities, reasons for the repeat visit, abnormal findings, etc. Then the issue is when the patient comes back in for whatever delay of the surgery was, if it's the same surgery but there was a delay, you would bill an established patient code for the follow-up, but you can still use the Z code, indicating it's a clearance for a surgery. Sorry, now this is where we're talking about the lymphoma. So you're removing a benign lesion. You can bill as many units as you need removed. Now there are several factors in this though. Number one, what you want to do is have good control on your front end, because what it seems to be is several people are having trouble getting two or more of their medical record, there are two or more of these lesions that are removed getting paid if they extend more than two. So you want to make sure, number one, you're billing the correct CPT code. You want to make sure that you are billing, that you have verified your benefits to ensure that there are no policy limitations or requirements for referrals or authorizations if they exceed two. And then most importantly, you want to ensure that you are actually billing the appropriate diagnosis, that you're using the appropriate informational modifiers and payment modifiers that tell the plan this is a separate procedure from the other removal. If you're not doing that, they're going to bundle those and say this is not necessary because everything looks the same. You're using the same diagnosis. You're not using informational modifiers saying this is on the right side, this is the left side, it was bilateral, this is separate of the other procedure. If your billing agent is not doing that, the plan is going to limit the number of lesions removed, and they're going to start denying. So you really want to make sure that you're using the appropriate modifiers and are coding, diagnosis coding appropriately, as well as CPT.
Okay, that is your billing questions answered. If you guys have any questions, you can follow up with me. You see my contact there. It's just tfells@medimobile.com. If you have anything from Morgan, please feel free to contact me, and I will get them to her and get you guys answers. We appreciate you guys being here very much, and we'll catch you on the next one. Have a good day.